Thank you very much, Mo, for the introduction. It's our pleasure to be here from the UK. And what we want to do is to introduce our experience with the Hybrid Base G and where we think it fits into your workflows and what you can do with this in practice and in the lab. And the idea of today's talk is you're going to see what I do in the practice. And this is me. I'm a dentist based in Clapham in London. And you're going to see how this relates to how I work with Steve, who is based out in Yorkshire. So really, we work from the practice, and I send work to Steve, who's remote. And the main thing we want to do is to show how these solutions help and benefit patients when we use them. So we're going to start off really, and one of the things I'm keen to talk about that I think this fits in a really unique place in our use is with immediate implant workflows and what we're able to do with the Hybrid Base G and how this will then relate to what you can do with your finals. So the idea is to talk through some of those workflows, and then once we've talked through some of those workflows, to then show you how these work in practice. Now, we're all aware, and this is not new, of what we do with digital workflows. We collect data, we get a diagnostic wax up, from there we make a surgical guide, place the implant, make a provisional and a final. But you see Steve standing over there, and the reason why he's over there is, as much as I like to say, look, it's planning, placement and restoration, we're all aware about the role that labs play. And actually for me today, being here amongst all these technicians, I feel like a slight alien, and I feel like I'm cheating as I wander around the corridors. But really today, and I think a lot of this meeting is all about all these stages where the lab is involved and how we communicate this information, and how actually the Hybrid Base G has already been made in a way that it fits into a fully digital workflow. And within this fully digital workflow, we'll show how you can take advantage of the components and how they work. I said we're going to talk about immediate, we're also going to talk about delayed, and the idea is within these cases, how would you use a Hybrid Base G? Why is it useful? Why do we have this component? So we know that when we do immediate loading, from the clinical perspective, we know that the implant design is important, the prosthetic components are important, and restorative workflows, but really it's those parts we're talking about, the prosthetic components, the restorative workflows, and the end-to-end digital is what we're going to talk through. So what are my challenges, and what challenges, what itch does this scratch? Basically, we have an issue when we place implants. The implants are deep when we place them immediately. We also sometimes have to place them with angulated screw access, which sometimes can be difficult. We also have to manage the emergence profiles when we do this. So what helps with this? And again, the purpose of today is to show how these components that we have really can help and are really crucial. So you're all aware of the Hybrid Base G, which we're going to go through in detail. We also have a tie base that goes onto multi-unit abutments. We're going to talk through those, but I think the first point to start is with this bit here, which is the scan bodies that are available. What's nice about these is the way in which they've been labeled. You can see here, it's called DAN 35, so D, dense Splicerona, AN for ankylose, 3.5 is the diameter. You can also see the other one there, ATE 36 Astrotech, EV connection 3.6, so it goes and makes sense. The other thing I think that's useful to know about these scan bodies is the fact that they can be, in terms of how they show up on an X-ray. There's a real story to this. This is one of my colleagues. He came in the other day and he said, Martin, I'm fitting this crown. I'm having real issues. As I'm fitting it, something feels like it's off. I'm not sure what's going on. And, you know, I said, take an X-ray. He took an X-ray, and if you look really closely, you can see just there, if you look really closely, you can see the marginal fit is not quite there. And I said to him, did you take an X-ray with the scan body in place? He says, yes, of course I did. And he took an X-ray with the scan body in place, and if you have a look, you can see the same gap there on the scan body as well as on the final crown. So it's a really expensive remake. Now, I had to take one recently, and if you look closely here, you'll see that there's no gap in that area. So this is the advantage of being able to show this on an X-ray. It saves a really expensive remake for the patient, for the lab, for the clinician. That's money wasted. The other thing we'll talk about is actually we have a fully digital workflow. This is an implant system. It's not relevant for today's talk, but there's a fully there's all of the different scan body sizes. There's also multi-unit abutment scan bodies that are available. So there's a fully digital workflow with the Elos components. And that's where this fits in. So I was on a call with someone the other day and they said, look, they said, oh, we've seen these for ages. Of course we've seen them. There's these tie bases everywhere. But what I want to point out is what is unique about this tie base? What is different? Why is it not like others you're going to meet? So the first thing we're going to talk about is this. The fact it comes in 4 different heights. When this was first coming out in the marketplace, you know, we're talking, and I remember saying to one of the team at Elos, saying, they say, oh, we're coming out with 1 and 2. I said, you're going to need a 3 and a 4. Said for what the marketplace needs, a 3 and a 4 mil tall is going to be ideal. The other thing that's really good as well is we've got the angulated screw access. But really, really importantly, with the angulated screw access, because we have a taller screw on these 2 channels, on the 3 and 4 millimeter, this taller screw means we've got enough there in terms of having enough of the palatal wall present. So we keep the same retention as we would, as on the shorter tie bases, but at a higher level. So the improvement in retention, Steve is going to touch on and show you how that works. So the other thing to talk about is, where does this fit in to this particular workflow I'm talking about? It fits in because we can use the hybrid base G here when we're dealing with single teeth. We can use it for multiple teeth. If we go to the fixture head, we can use it there. So again, a small 2-unit bridge can be used for that. We can also use it for full arches, and we can also use it again for whether we've got, again, these are the 2 different platforms with this implant system. And as well as that, we can also, within the Elos system, Steve is going to touch a little bit upon their customization and how they've got a way in which their customization is possible. So you can make custom abutments within that. So it allows us to address all of these issues within this implant system by using the Elos components, should we choose to. So first thing, let's talk about what the key part here is. So if we look here, we've got 4 different heights. So I want you to imagine when you place your implant, you've got 4 different levels you can place the implant at. And then the next thing we're going to talk about is you can then, from these 4 different levels, you can customize the cylinder 5 different ways. And by that you can have it short, you can have it short, medium and tall. This is how it comes. Then you've got the low angle cut and the high angle cut. So if we take that combination, 4 heights, 5 customizations, what does this mean? This means in practicality, there's effectively 20 different implant positions that we can get from this one solution. So this means we're entering a new phase in terms of what's available to us. In the past, we've had custom abutments. This we call a semi-custom abutment, i.e. you can customize it to a certain degree, but it comes as a stock component. So it's fitting into this really, really nice zone where we can use the customization, but it's a stock component we keep in place. So the other thing is, okay, you might say, okay, that's great, fantastic. How is this relevant clinically? So to me, as a surgeon, what I did was had a look at this paper. This paper is designed as a way that we can look at all of these different angulations of anterior teeth, and it classifies them according to that. So from this paper, we're looking at how anterior teeth sits. And remember, we're talking about immediate implants here. So within that, if we then just hack this paper and look at all of these presentations here, and when we look at all of these presentations, let's look at the different places where the implant might be positioned. Now, if we then take the hybrid base G, if we take the different customizations with the angled screw access, it means that in this scenario, we can place the implant there, we can use one of these semi-custom components. In that scenario, the class 1, we can place it there. We can use, again, a taller angle cut. You've seen a shorter angle cut used there. And again, we can have palatal screw access. Again, there, taller angle cut, palatal screw access. We can also vary the placement according to the collar height. There, again, we can place it. And again, one of the most radical is there, which would have been incredibly difficult to place that implant immediately in a position where we would be able to use a tool, where we'd be able to use a normal tie base. So you can see how it fits into a particular pattern as to how we're going to do that. The other thing I want to talk about is why this shape, all right? And from talking about why this shape, I just want to touch on this part here. So as much as it looks like others, you're going to see other things in place. There are these 4 papers that really have judged how we look at aesthetics nowadays and how we look at components of how we shape the subgingival area of a single implant crown. I'm going to summarize them for you with this slide. This slide goes through the different areas. So depending on whose paper, whether it's the paper by Pelacanos, Gomez Meda, or Oscar Gonzalez and co., we've got this zone here. This we call the blue zone, we call the critical contour, the cervical zone, or the aesthetic zone. The next zone there is the bounded zone. So the idea is the blue area shapes the gingival margin where we want the tooth to be. The red area should be as concave as possible for the immediate implant placement, and then the green area should be as straight as possible. So this that you're seeing there is with a customized abutment that you're seeing there, with a custom abutment. And when I flick to this next image here, and you'll see how Elos have really cleverly designed this so that the different zones that you've seen by the previous authors that we know are useful are contained when you design this restoration correctly. This is partly because of the subgingival shape of the component, the fact it starts out very narrow, and then you can customize it from the area where you need to go wider, i.e. the bounded zone, to then the blue area, which is again the critical contour that you see there. And again, that's just a repeat of the slide. We also talked a little bit about the chimney height. So what you see here is a patient who's had an immediate implant. This is the standard chimney. It goes to roughly, let's say, that height. If we, it goes to that height, and we can see the crown on top of that. Now this patient went away, as he did, and he was told to come back. He didn't, and he fractured that. It meant that when I remade it, I'm able to use the pictures that you've seen, and by having two things. One is a taller collar height. The second is enough material underneath supporting the resin. It means that, fortunately or unfortunately, he's not come back for the final, but really we're after benefiting patients. So really from that perspective, it's been successful, but I would love him to come back so we can do something more for him. And again, the other question I had from someone is saying, look, this is the same, we've seen these before. What I want to show you is unnamed company, other tie base. So here you've seen how I've had to customize that tie base for the same critical and subcritical contours there. So that's what I'm used to having to do, is to get something like that, trim it, and just going all the way through. That's the patient with the provisional. And again, here you see again the scan body 22 in place. And again, just finishing that off with something that's customized. Again, one more example of this. Again, here I've said to the lab, give me a tall tie base. They've given me a tall tie base, but this looks like it's slightly, can you see how it's slightly wider around there? You've seen how I've had to customize it, and I've had to do that chair side to this sort of shape. And the reason being is that we know that when we have implants that are placed a little bit deeper, either in immediate or delayed, and we want to get results like this, in the past we've not been able to do that with tie bases due to the shape of what we've got. So we end up with, again, a way in which we can address things like that by having the right shape of tie base. So really from my perspective, I've dealt with the challenges of implant depth. We have here within this component 4 different collar heights. Angulation, we've got up to a 28-degree angulation. Emergence profiles, we've spoken about actually the shape and the emergence profile that is contained within the product that allows us to do that. So really, it's really helped in those scenarios that I've shown, and I'm now going to hand over to Steve.
I love that. Challenges over to Steve. So I'm a technician, so there's going to be a lot less science and a lot more of what we do every day. So this isn't a bragging slide. I'm very, very fortunate that so many of these organisations and groups allow me to be on their board, allow me to educate, and allow me to be a part of many more technicians and surgeons' journey. But I'm a dental technician first and foremost. I work at the bench, even though it's digitally, every single day. And that for me is the most important title I have, because along with our surgical partners, we have a real impact on people's quality of life. Everything we do has a real impact on someone. So I always tell my team, bear this in mind. We're not just making widgets and components, we're doing it with a goal. What is my goal? Avoid failure. That's it. Simple. So when we make our choices on the components we're going to use and how we're going to restore cases, I was anti-tie base for almost all my career for one reason. There was too many flaws and issues. We do a lot of rework for other labs. Now, when I look at this failure, this isn't really saying that tie bases are good or bad. There's some very switched on people, and I saw the smiles. We know why that failed. That is all failing due to cantilever loading. There's a lot of issues happening around that. One was, Martin talked about it, it's the ratio of the crown to what's retaining it. So we know from more and more of the papers, and Lyndon Cooper's going to publish this one, that the lower the base, the higher the crown, the more chance you've got of debonding it. And although Holger Zipprich did this on implants, it's the same philosophy. We don't just clamp up and down on crowns. They're always getting this lateral loading. And that is why we're seeing these breakages. Because now we can look at things with finite element analysis and actually see where that load is. So remember that crown we looked at. Look at where it was failing. Now this was actually a study, it's a great study, but it's actually on different materials. But all of them were having the highest load and fatigue right down there at the neck. So most of the crowns that you'll see, and Martin will show one later, with zirconia, that's where it's always thinnest. Zirconia is an awesome material. We love it. Like we do 95% of all our crowns now are zirconia. But when you even take it down by 0.5 mil, you substantially sacrifice strength. So when we've got these narrow little collars, of course that's where it's going to break. So what else was happening with these and these and these? It's all to do with that cantilever loading. That force is happening down here where it's weakest and it's blowing it out. So when I saw a case like this with 2 molars, was this going to be a tie-based case for me? No, but I worked with Martin. So I was convinced that I would be doing this with a base. I was like, okay then, let's throw it into design. Let's have a look. So scan body 22 that we've looked at. Now as a technician, this is what I want to see. See that blue? That blue is a tolerance map. That tells me it's an absolutely perfect match. Perfect match. So already, I'm not worried that I'm going to give Martin a job with adjusting occlusion or doing contacts. So this is a very important thing for me. And what you're looking at inside it is the high base, so the fully uncut base. So the first thing we can do is instantly in the libraries, have a look at those, choose what it's going to be. Now I know that so far you've seen Ankylos, you've seen EV, but this actually covers a whole range of all the implant systems, all the major ones that you're going to work with. But these are obviously the examples of our day-to-day work. And it isn't just ExaCAD, it is 3Shape too. But the mesh and merge is perfect on both because the scan body is so good. So we get them in. And what can I do? I can instantly look at it and think, okay, I've actually got a really good retaining body to crown ratio here. I'm already happy. What else did we do? I'm going to avoid them being thin at the neck because we've got the height to get away from where I'm worried about bone. I'm just going to come out as fat as possible, as soon as possible, just below the tissue level. So I'm going to avoid that because I'm not having to do this anymore. I'm going to come straight out because we have the right options for it. And giving credit to Martin, he's here amongst the technicians, but obviously this surgeon's here. Why did it work so well? Because it was planned. Honestly, if my number one takeaway for everyone here is, with a bit of planning at the beginning, you can utilize so many more of these solutions and avoid custom abutments. 90% of the cases I do are custom abutments. I would say at least half of them could easily have avoided that, easily. So we've planned it, we looked at it, I discussed it with Martin, and then of course we go and we build the models. Now look at that analog. Boring geek that I am. I looked at that analog and I thought, it just seems heavily overcomplicated, massively over-engineered. Most of them you see, they're just very simple geometries, but there's a reason for that. That's a production decision. It's so much easier and faster to turn out simple analogs. This one is a lot more time consuming. But what they were doing is this printed model, and I'm going to have a go at printed models quite a lot through my talk, is the problem. In the old days, when you used to get an iTero one, it was always milled, and everything fits perfectly. The problem we've now got in the modern era is all of the printers have completely different variables. So what they did was say, okay, we know the marketplace is going to have such a variable on the printed materials, we're going to make this with specific features to ensure it's completely accurate and compensates for the lack of predictability in the printers. So there's always the thought process behind these. Uncut, straight on them, detailing from our ceramists, and then, of course, as I was saying, I'm avoiding all of these small areas, and I know I've got a good body in there. So I was convinced. Because my first go-to as a lab owner is I cannot afford remakes. I just can't. I've struggled to support the surgeons I've got, and I cannot have work coming back in for free. It's just not going to work. But also, it's not just poor me. What about you? And now these are conservative. I saw Antti Benkovsky recently. He's putting up more towards £500 or £600 an hour is what he optimally needs his surgeries to be running at. So if you get somebody comes back in with a fractured crown, what's that, 20 minutes off, rescan, back to us? That's your valuable time. So we're really doing this for a long-term philosophy. And I've always done this because Martin covered it. It's the avoiding bone engagement. More and more implants that we see in our lab are all going deep subcrestal. So we're seeing more and more of that. So we're having to be very wary not to risk impinging on the bone. Martin, this is yours because it's science.
So there's a couple of papers that kind of guide us a lot according to this. This is the first one, and there's about 3 or 4 that fit into this category. On this one, it says we need a restorative angle of less than 40 degrees. i.e., if we come up too soon, we're going to find we have an area where we get sometimes food trapped underneath, or patient finds it difficult to clean, and we end up with marginal bone loss if we do that. And again, another paper. This one's a little bit more, again, you're going to like this one, Steve, lots and lots of numbers. But what I like about this particular series, it gives you takeaways. So you have a look, they've looked at different angles, they've looked at how, the emergence of that. But really what it says is when we're designing CAD/CAM abutments, the emergence profile should be concave or straight within the first 2 millimeters of the implant abutment junction. So really, this is where having the 2, 3, and 4 millimeter taller allows us to do that. And also the angle and shape of that abutment is really, really important. And you can see there are 3 different profiles that you can see that it goes through. So this is me when Steve sends the crowns back to me. You can see how he's managed the thickness of the zirconia in critical areas, how those have been bonded nicely. And again, it's a very straightforward workflow. Patient comes in, healing abutments off, and from there we fit the crown. So really nothing, what I want is a stress and hassle-free day, and that has provided it for me. So in terms of, we've talked through some immediate and delayed, but I think we're going to touch a little bit on communication, Steve. So I'm going to hand back to you on this.
Okay, thank you very much. Well, look, everything, I love technology, I'm a geek, but this has never changed. The optimal workflow, the best results come from good planning and collaboration. So Makoto Yamamoto told us this right back in 1975. When I was born, this book was published. Now this is still a book that my technicians all read because we still believe in this philosophy. You plan everything to the final and then you only want just enough material for the layering for whatever you're going to have. Now I've told you I'm time poor. I don't know what it's like in America, but I'll tell you now, for me to employ a good dental technician, it's 60 grand plus, and I'm in Yorkshire. Do you know what I mean? I don't even know what that would be like in London, but it's that competitive. So I can't have them spending a lot of time on a manual process. So what do we do digitally? We start with the end crown in mind, we look at the ideal emergence, and then of course, we can then say, is it going to be a custom pre-mill, or is it going to be a new HBG? Everything can be done there, all the way back to the first bit. So what we're going to talk about with communication, we're going to talk about how much easier diagnostics have become. So 3Shape does the same thing, but here I'm using Exocad. So what do? I use a biogeneric flip copy of these teeth for the central and the molar, and that setup, honestly, I hate saying it in front of mine because he's going to want me to do it cheaper all the time. It genuinely takes me 5 minutes max. That's great. Now what have I got here? I've got something I can send to Martin. Now we call this level of digital workflow enhanced communication. Okay, so we've had communication we've been used to for years and years. What's the number one? When we all started, you all wrote a prescription, you sent it to your lab, and that's great. And Abraham Lincoln's statement here still rings true. The written word is incredible, but it has so many problems. Number one is misunderstanding. Now, Rachel Ray finds inspiration in cooking her family and her dog. Without the break, it sounds like all the family have been eaten and the dog's going in the pot. Now, that's just a simple grammatical thing, but actually, the real truth of it is, in the past, I would say our remake rate, honestly, was probably around about 8 to 10%. What were the majority of those remakes for? Misunderstanding. We didn't really deliver what the surgeon expected. So we were reading the prescription, building our own mental picture, and then returning it. Fine. Why don't you just pick up the phone and talk to your lab? Well, there's a number of reasons, actually. Have you tried speaking to your labs just randomly, or try to get hold of your surgeon? No. Everyone is so busy. So finding the right window of time to do it doesn't work. But also, you ring me up, you give me a lot of instructions all in one go, and I'm still then going to have to mentally go away and try and get the right picture. Not proud of this, and people who've seen it before will know it's true. I was coming back from Norway, and my wife rang me at the airport and said, Steve, we've had a family discussion and we're going to get a dog. I was over the moon. I was over the moon. I grew up with Vizslas and Weimaraners, I live in the Yorkshire Dales, and I love running. I was on the plane visualising my new future with this lovely dog. I got back, she picked me up at the airport in Manchester, and she took me to see the breeder of that. It's not a dog. That is not a job. That is like a chubby ferret. So I was like, no, 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 no. Get in the car. That is not coming home with us. Well, let me assure you, my wife gives zero attention to what I say. And the worst bit is recently, I think the dog's become aware I didn't choose it as well. So if I can get something that simple, I've been married for 20 years, and I can misunderstand that because we have our own relative thought process. When we talk about the level of complexity we get into, it's big, but it doesn't matter. I literally just send this to Martin. When he's got his own time and convenience, he opens it from all angles and says yes or no. So this is what digital really does for you. It frees you up to deal with it when you've got time. And this is actually a great slide that I stole from Martin. But we all know, actually, humans, we are so much better retaining information with what they call dual encoding. So it's an image and the text. Works every time. So why is that important? So if that case, where the positioning was great because he did plan it well, turned out needing something else, what would I do? I turn to a pre-mill, a custom abutment. Why? Because this implant here, if it had been placed as well as I'd hoped, like Martin did with his, I wouldn't have needed this. But here, they wouldn't get away with that base solution. So we're not here saying to you, it's going to be HBG for everything. Sometimes you need a custom. But luckily for us, in the Elos family, the same libraries, you can go straight to a custom. And I do this with Createch or anybody, milling companies that you like, they can use these pre-mills for you. So, why am I doing it? Well, we saw where the other ones failed. I'm using the stronger titanium to make sure that we're actually negating that kind of cantilever load away. And this is just zirconia's even thickness all around, more passive. Good bonding area. And this is only really feasible for us because this pre-mill is so accurate. Why is it so accurate? You know, all pre-mills are accurate because they didn't just do the abutment, they actually looked at everything. I do not want someone milling me the interface. I want these as a pre-mill because I know that has been validated. I know it's a great engineered fit, and I don't like it when it's coming out of a disc mill because that is not completely controlled, whereas I know this is, so I've got peace of mind. But this was the genius. They didn't just put these in the market. They were like, no, no, no. If we're going to make it completely accurate so you can have a split file, we need to know that there's no vibration or miscalculation on what it's doing. So they invented their own locking holder. So it's always in exactly the right position and it doesn't have that tiny vibration. So when I bring my crown to meet it, they always meet perfectly. And that for me is incredibly powerful. Because technician time. I can't, when I don't want to, get an abutment back and have someone rescanning it. It's a worse fit, but it's also twice the work. So this is a full end-to-end system. This is what I like about it. You've got all the bases in the library, but if you've got to go there, then of course you come across to this. So they've done the full validation with different softwares, but also importantly, they've done it with different machines. So it's a full validated workflow. And I think that is important because then we know with confidence that we're getting predictability and repeatability. So back to a bit more science.
You're backing away from this today, aren't you?
I'm just running away from the slide.
So one of the things we know is the materials we use subgingivally are really, really going to be important to how well our soft tissues and our hard tissues behave. So not only is it the shape, but it's the materials. This is a paper that looks at what happens when we have polished zirconia on the undersurface. And if you can't really see it that well, but we get cell adhesion, we get soft tissue cell adhesion to polished zirconia. And the other material as well that we need to keep subgingivally is titanium. The titanium and polished zirconia are ideal subgingivally. Yep, sorry, did you have a question?
Yeah, sorry to interrupt you. Say polished zirconia versus glaze. Right?
Yes, yeah.
Glaze ruins it.
Yep.
Yeah.
Yep.
To be super polished, and glaze should not be in any subgingival area at all. You won't get that attachment with the glazed in place. So you're back to what we used to have with metal ceramic. In some ways, you won't get the same attachment, and I think it's taking away a lot from the material and what you can do with it. The other thing we're going to talk about, and I'm going to hand over to Steve halfway through this, is when we're using these, how do we decide where to position this? So here you're seeing a provisional, and for this provisional, again, it's another one where if you look very closely at this, you'll see that we had previously, sorry, this will just take a minute to start. If you look very closely at this area, you'll see here that we have a small crack in place, and that crack has happened because, again, as I described before, we've had lateral load on there and we don't have enough to contain it. So when we've milled the new, milled the new crown with the HPG, we've put the margin in that place. Now, what I've said to Steve, and I sent him this slide afterwards, saying, in future, if we can just raise that collar to that level so that in the ideal position, we would have maybe 1 millimeter or 2 of this in this area that's not the titanium. And so in some ways what we want is that HPG up to that sort of level. That's in the ideal world. So the positioning in terms of the height is also critical and key. And so this is why having both a long and a short angle cut is critical. So if you have to move the junction up, you still are able to cut it and have enough material in and around there. It's really 1 to 2 millimeters maximum, so that you can build up the critical and subcritical contour in that area. So one of the things that we're going to talk about is workflows. And really, when we're doing workflows for immediate implants, and again, you'll start to see some of this in action with videos. This is a patient who's come in, and we're going to need to replace his upper right one. His upper left one is an implant crown that we've had in place for a number of years. And unfortunately for him, if you have a look here, you'll see this has dropped down ever so slightly. We know that this is because the crown, unfortunately, has fractured. And what I would love to show you is, again, how we treated him in the past to how we treated him now. So we're seeing 2 centrals replaced at 2 different times. This was the first one we replaced. This was the second one we replaced. And we're having a look at 2 different techniques, guided versus freehand. And again, just a quick video showing the extraction, and from the extraction, what we do is we then go through and place the implant, and at the end of placing the implant, we have pre-planned in the software what size of tie base we need, what size of the hybrid base G we need. We also know what cut we need in the software. So we've been able to think about this, get this all ready, so when it comes to placing the implant, and then afterwards doing this part where I'm using the old crown to pick everything up, we know what we need in the cupboard. So it means that our pack that arrives from the lab is a guide, is a hybrid base G. Sometimes if Steve is kind enough, he'll cut it for me, but most of the time he doesn't. He lets me do that work on my own. And you can see here how we just do a very simple pickup that you'll see in a second. And from that pickup, we then put the crown back into place and just proceed from there. So again, there's a few bits we'll touch on in other cases that we'll show. Again, just go through the pickup. I won't spend too much time on there. And really to show you that when we come to fit it, this is it. So what I love about this picture is this is the evolution of what we had. This is what we had before. That's your usual 1 mil tie base collar height. This is what we've got now. And you can see the difference in terms of the look, in terms of where the metal is. We don't have composite in the subgingival areas. We now have titanium in the subgingival areas. And we're able to, again, just provide the patient with that. And again, when we have a look here, yes, please do.
Have you noticed the papilla height, the loss difference between old and...
Between, in this case or in general?
In general, but this case as an example.
In some cases you do lose a little bit, mainly the distal papilla on central incisors.
The different height of the
With a different height of the thigh base, I can't really answer that because I would need to see many cases over a period of time to give you a definitive answer.
There's an advantage.
Of,
Maintaining your patella.
is there an advantage of maintaining the papilla?
If your thigh base height, let's say, is the old one you did?
I think I can, Martin, I
Yes,
can answer that.
so-
You've got a slide coming up, so where the bone is actually infilled right up by the thing. So the theory is where there's more bone, you will get more tissue.
Oh, okay, so
Yeah, I think that's what he's asking.
I think
So you don't need a black triangle, one versus the other.
no, not particularly. I think that with the immediate, what I'd expect is a little bit of a papilla loss there between the two centrals. Yeah, but I can make that up when I make the final crown.
I just wonder if there's any clinical advantage one versus the other.
Um,
Sounds good in theory, but it's in humans.
I think the best way I can show you is a slide later on, where I can show you how we maintain the bone with these components, and that should hopefully give you some guidance as to how we maintain papilla. Okay. So if we have a look and we talk about the next case, and again there's a few others coming through. So if we have a look here, we're replacing a lateral, and this is one where we didn't have a huge amount of time. The patient came into the practice, had fractured his tooth, and needed it done the next day. And here what we're able to do is to extract the tooth, and then from there, having placed the implant, we weren't able to use a guide on this occasion. And what we're able to do then is just put a scan body on there, send that off, and then basically have something designed so we can fit a provisional restoration really, really quickly on the same day for the patient. And in terms of the question you've asked is, okay, so when we've got the papilla heights there and we support the bone underneath that, I believe that's going to help to support the papilla long term. If you look at immediate implants, what we tend to find is the distal papilla tends to lose a little bit when we do them. But overall, we've got so many strategies for maintaining papilla that I think that this is something that works as well as anything we've got in our armamentarium. Where this really, really comes into force, though, is when we're able to use pre-made prosthetics. So this is for surgeons who want this done quickly, and we're able to take advantage of this because we have all of the components in a library. When we're doing our planning, and you'll see this video play here, this is in a particular kind of guiding software, others are available. But you can see here we've got the implant position because of the height because of where we've had bone loss and the distance between the gingival margin and the bone, the implant's going to be placed quite deep. And as the implant's going to be placed quite deep, we can then select a collar height, we can also select a cut, and we can look at this before we do the surgery. Meaning that I can say to Steve, I know where this is, and as a part of what I've got to do in this particular software is not just select the abutment, I've got to select the scan body as well when I go through the Exoplan software. When I select the scan body, this means that when Steve sees this, he sees it as a completed case. It means that he knows the implant position, and what he's provided me with here is provided me with a pre-made crown. You'll notice also we've used the non-index version. This means that if I have a small issue with timing and depth, I don't need to pull the implant round anymore. I can just place this on. Now for this particular implant system, you can use non-index and torque it at 15 or 25. We're obviously going to change it to something indexed for the final. And again, there's some subtlety around that we'll get to. So this is everything in place. We'll see the patient here. Extraction. Now, that's a long lateral incisor, isn't it? That's a really, I mean, I've seen shorter canines than that. I mean, that was one of those where, you know, that photo made me, and also there was nothing to grip onto it, so I was very happy to get that out on that day. That's one of my happy places. And here's to show you where the bone is around there. So we know that the implant's going to be placed pretty deep. So when we go through, use the guide, everything that we've planned, this is the pre-made crown that we're going to put in. A little bit of biomaterial in there. That's it in place. And this is pretty much on the day. So what I liked about this is normally when I'm doing it, you've seen how I do the pickup, we end up faffing around and doing all this stuff. My nurse looks at me and goes, is that it? Is that it? She's expecting like a whole hullabaloo to take place. When I've just fitted the crown, she's gone, oh, okay. So again, we talk about saving of time. This is where we're able to use these workflows. And again, I'm hoping this will answer your question. So we can see here the patient before, we can see the patient after we've had the surgery. This is when I've sent them back to the referring dentist. The referring dentist has not been kind enough to send me anything, but what I wanted to highlight, and I'm not sure if you can see it here, is if you have a very close look at this area here, and you look at these two, you'll see that actually we've had bone growing right up to the top and in areas where we stayed away. So again, the shape of the component, the material of the component, everything around that has really, really helped. And I still keep asking the referring dentist for a picture, but he's not yet been kind enough to send that to me. So really, I think rather than showing you yet another tooth, the main thing to show you now is just again another case where actually this really comes into the fore. And this is a complex case where we're dealing with this patient who's having some orthodontics, who's got 2 adjacent implants, and 2 adjacent implants back to papilla in your question, sir, is one of those really, really difficult cases to deal with. So we've done our planning as to where the teeth are going to go, and they've obviously started like that. And from there, we've taken them through some orthodontics with an aligner company. Other ones do exist. And from straightening the teeth, we've gone through, and the patient has gone through a number of orthodontic appointments, shall we say, to get to the point where they're ready to see me. Now, the aim here is to replace the upper left 1 and 2. And you'll see here we've got, again, slightly less papilla there at the beginning. You'll see it's slightly blunted, probably slightly a little bit inflamed in that area. And this is the point where they come to see me for me to replace the upper left 1 and 2. And again, this is the planning that we'll do, and we'll go through, have a look and make sure we can plan everything. And again, the important part here is, again, in the same way as we did before, we plan where the teeth are going to go using, again, some sort of smart design and digital wax up. And we reach the point where here on the surgery, and when we're planning the surgery, we can plan what tie bases we're going to need from the Elos range. So it means that when we come to doing the surgery, which you'll see here in a second, we've already planned everything. We've got the information we need. We've got all the parts that we need. So as we do the surgery, I'm not going to make you sit through the video here. There is a video as we go through the surgery. But again, in terms of time, because the teeth were ankylosed, we've done a technique called socket shield. And again, this is a really delicate technique from a prosthetic perspective, because if we push on the shield at the time, if we have the wrong shape of subgingival component, we can cause everything to fail. So again, we can see here the tie bases. This is them picked up. This is them at the time of fit. And again, what would have been really quite a difficult case to do, we've simplified by having workflows that allow us to actually go through and treat the patient in that way. This is the patient pretty much at the end of surgery. This is them having healed. And we can see that papilla's creeping down nicely for the patient over time, just there. And again, this is the patient as he's left, and we'll see that papilla creep down. Unfortunately for me, he's gone off to South America, but he says he will be back at some point for us to finish everything when he's done.
I just want to see the shape of those temporaries.
You want to see the shape of the temporaries there? Yeah.
Slightly concave. Are you still supporting the tissue?
Yeah.
You said the extraction, the socket shield,
Yeah.
are you sectioning the root and leaving that buccal aspect?
Yes, that's what I'm doing there, yeah. And the danger with that is that if you have your prosthetics too bulky, too soon, you're going to push on that bit of root, which means that it's not going to work. Yeah. Okay. Thank you for the questions. So moving on, let's deal with one final case before handing back to Steve. And this again, the reason for showing this case is a way in which when we've got a case where we have a lack of bone, as you can see here, and we're not going to be able to place immediately with the best will in the world. We're going to have to go through some planning, and you can see here in the CT scan where we're planning on placing the implant. We go through some sort of digital wax up with Steve, and from that he makes me a printed denture, as you can see here. Steve, do you want to talk a little bit about the material that you've used?
Look, one of the things that's changing the most rapidly for you with your labs is materials, material science. It's just coming on leaps and bounds. Now, doing something like this used to be quite time consuming. Now with, like you say, others are available. We use a lot of this ProResin Straumann Crown X. Even for a simple flipper denture like this, unbelievably strong. And it's just for us a very simple case of print it, little bit of staining, and that's the look you're going to get from it. So we use, for our provisionals, for our try-ins, anything that you're going to see in the bridges, we use a lot of this material. It's sold as a final. We don't use it as a final. We just use it as a good long-term provisional. So that's one thing I'd say to you is, you in your lab, and like we'll be doing it here, we should really be hunting for the best materials now, because we've got great base solutions The only thing that can improve that now in the digital workflow is better materials. So that's our next go-to, if you like.
So I think this was an older case where Steve didn't
Sorry,
do
do
it
you need a
that
picture
way.
of that?
Okay, right. This is where Steve and his team didn't do that. So you can see we've got a little bit of pink in place. So in this case, I'm going to flick through this quite quickly because the relevant part is a little bit later. What I want to show you is we go through some augmentation procedures for the patient. Then once we've built up the hard and soft tissue, we then go through to actually place the implant. So once that stage is done and the patient comes back, we've got this tissue to work with. And when we've got that tissue to work with, you can see there where we've augmented everything. We're then able to go through and literally place the implant. Now, the issue we have here is that there's two things I want to highlight. The first thing is that because the patient travels from a long way away, she doesn't want to come back to have the healing abutment, then the impression, etc. So what we're going to do is we're going to scan the patient at the time we place the implant and then make the ideal shaped tooth. And this is where sometimes if we have not planned for using the HBG, which would mean having this slope facing buccally, if I had it in the correct orientation to take advantage of the angled screw access, it means I'm not able to do that. So it's off to Steve and I say, listen, I'm sorry, I didn't realize, can you make me the ideal shaped tooth based on that? And so at the time the patient is healing, Steve is busy in the lab, and this is the point where he's able to do his crown design, but he has an open flap, so he's just got to copy the other tooth and give me the ideal contours. Steve, it's over to you now.
Yeah, so it's exactly that. And as Martin mentioned, this is where we're going to go to a custom, but purely because of the timing. So to make the best use of that angle cut, you've got to have the scan body with that slope facing buckle. That allows you to utilize the angle cut. If you don't do that, then we're across to one of the customs. So that's why this was a custom in this particular instance. So again, and very much for your questions, when we look at these are only polished there. That is not glaze. We do not use glaze anywhere in the subgingival emergence. A lot of the hybrid bases that I'm looking at there, I kind of cringe now, because in the early days I was too cautious. We were going too deep, so we were still not utilizing the full height. And Martin, his constant badgering at me was, higher, go higher, because we're not seeing the tissue receding. We are seeing it being stable, so it's having the confidence now to know that, in fact, those 3s and 4s that he was talking about, we're utilizing them a lot more now. So that's why we're getting the contour with the titanium, less with the zirconia these days. Yeah, with the same sort of thing. I mean, we know you're not going to get the same sort of attachment, which is especially because we're using the acrylics. That's why we're actually now saying, look, use the 3 or the 4. So all of it's titanium, and really just be 1 millimeter below the tissue with your crown. So we're utilizing the depth more. We weren't before. I was just too cautious. But now I've got the confidence. If you see more of our recent cases, you're seeing them literally 1 mil below, and then the crown's developing. So back to you, Martin, for placing it.
Okay, so in this case, what we've done is because we have the pre-made temporary, we're able to open a little flap, just suture around it, let everything heal. And again, you can see how far we've come in this case for the patient. And again, we talk about zones. You can see here, very narrow as we come out in the crestal zone. And then as we get to the bounded zone, the red zone, we flare up to the critical or subcritical contour, as you can see there. So again, we can plan where we're going to get papilla, take some pictures for Steve, say, listen, can you design this? And this is where we have a slightly interesting debate, because when we looked at this, I'm looking at this, I'm thinking, I need that tooth a little bit taller. To me, in my eye, I think that this needs to come down there, and I'm communicating this to Steve. Steve, on the other hand, sees this ever so slightly differently. He looks at that, and he doesn't see that, because when he's looking at the computer, we're arguing and going back and forth, and this is me adding a little bit of composite and saying, this is how I want it. If you look closely, you'll see I've added a little bit there. This is why I want it. Then I hand over to Steve, and he literally, here you go.
Clone it. And this is coming back to the communication we spoke about in the beginning, because now that we've got that, we import it in, and I'm literally going to clone it. So he's not having to explain it or draw it in a bit of thing. He's literally added a bit of composite, scan it, send it to me. Easy. So that's the best communication you can get, because I can't get that wrong. And I can get a lot of other things wrong, but I can't get that bit wrong. So that's exactly what you're seeing here. And you're seeing is with the emergence profile, everything we're doing, cloning that. And again, because Martin loves to prove he was right, that was where I was, and this is where we needed to go. So yes, you were right, Martin.
On that one occasion,
I agree.
I mean, it got to the point where he's sending me pictures to say, look, no, it's this tall, this tall. You know, you would think our wives and families might want to see us once in a while, but no, we're arguing over a millimetre of tooth there. But in the end, it's worth it for the patient, because when we're able to deliver this for the patient, you'll see this come together nicely, and we can fit that for the patient, and also we can have a look at the tissue that we have in and around there. This, again, we end up with a happy patient with the right height of tooth, thankfully, Steve, as well as, again, this is the important part, is how the biology behaves with all of these. Is this a case which we've had to treat in the practice where the wrong collar height has been used?
Yeah.
And we can see how actually when that comes out and it breaks all of the rules, it's also, I think there's a bit of cement underneath there. The patients come in and that tooth is unsightly. You can see the area where we've had an issue just above the gingival margin there. We've got bone loss. So unfortunately for this poor patient, we have to go through all of that to reconstruct, to get the right shape of tooth in. And what I like about this, we've gone with the same brand of implant, but different design of prosthetic. So the lesson from here is when you have a look, he's had to have that all redone because of a choice as to the collar height of what was there. And when we end up in the end, you saw how it was much longer before. We can see now how we've got 2 even teeth. Unfortunately, he's chosen not to deal with any of the other teeth around that, which Dr. Trowler would have loved him to do, but that's how the cookie crumbles sometimes. We're going to briefly talk again about how we use, again, for multiples. We've got this solution here that we're able to use, and with this tie base that attaches to the MUA, we're able to do multi-base along a variety of different platforms, again using the Elos system. And it means a case like this, which I'll flick through very quickly, because from the surgical point of view, we've put in 2 implants, and having put in 2 implants, we've attached 2 multi-unit abutments to that. We've scanned them using the software, and from there we've sent them off to Steve, who's going to talk a little bit about the bonding and the models and the importance of the next stage when we're building the final.
And we're literally now in the last 5 minutes. So this is interesting. From acquisition to the bridge not fitting. Why? Why does that bridge not fit? What's going wrong? Well, a number of things are going wrong. Do you remember how in the lab, what do we always trust? The model. The model was master. Everything was worked to the model, always. The problem is that philosophy that we've all been trained to do doesn't hold true now that we've moved into printed models. You don't want to trust the printed model. Of all of the areas we see the most deviation, it's in the production of the model. So this is an overlay of the scan versus the model that's been printed under a better printer, but what we see overall is we're not getting that one-on-one match. So this technique does not work well if you do it on a printed model. So what did they do to prove it? I love Elos because what they basically did is they took this, imagine this is the known master, everything's bonded and it's completely passive. So then they took the scan of this model and then they produced some printed models. So we know the bridge is perfect, bear that in mind. So all we're testing is, can the models be reproduced as accurately? Well, the answer is no. So this is one of the labs. They sent these out to a lot of different people to produce. That's one. That's one of the best medical print companies, and even they couldn't make an accurate reproduction model. So if you were to bond on that model rather than the stone, what are you going to have? A slight misfit. What's the issue there? Well, that gap, how much screw force do you think that is? It's 45 kilograms. It's a Labrador. That's incredible. So of course this is no surprise. A friend of mine sent this to me and said, where are we going wrong? And I was like, well, that's a printed resin. Did you do that on the model? They were like, yeah, of course we did. We always do it on the model. I was like, that's where you're going wrong. Now there's a few innovative things that we have with the HBNH. One of them is you can actually bond that in and trust it. You know that's perfect. Because if it doesn't fail there, it will fail later on. So that's really my one takeaway to you all. Please don't bond bridges on the models. You're actually able to trust the zirconia structure now. And it's a shame that with Phil, he's been doing photogrammetry, amazing. So you could do that and just put them in. But if people don't have that and don't have a good way of getting an accurate scan, just do a metal jig and send it to your lab. Because this shows what was true in the mouth, the printed model isn't reproducing it. So back to you, Martin.
So in this particular case that we've talked about, Steve has gone through that. He's made sure that we bond it correctly and put everything in the right place. We've been able just to finish that off by, again, just going through this process and procedure, placing that, and we can see there again, we can see, obviously, we can see the components in place, we can see the implants in place, and we can see how everything fits together. So again, the take-home messages from our side are, the first is obviously we can use immediate implants and we're going to get really, really good aesthetics from there. But I think the key parts of the provisionals, we've talked through the importance of the provisionals, how we shape them, the materials that we use around there, and the contours, making sure that everything is going to work to benefit ours. And having the components that allow deep placement, angulated screws, and offer adequate support for the immediate loading process and placement is really, really critical and key. And Steve, this is over to you.
Yeah, and look, as we were basically saying, do many people know Elos? So a lot of places that I lecture and speak, they don't really know Elos. Okay, so you don't know Elos, but you know this company, and guess what? They're exactly the same. Nobel, right back from Brannemark, BioHorizons, many companies we can name actually all trust Elos. And that's why we trust Elos. These aren't a new company. They have been so long established in the marketplace.
Okay. Thank you very much for your time and attention today.
Thank you, everybody.